So, welcome to another edition of the Osteopathic Lyceum podcast. We are here again with Dr. Sandra Monteiro, who was my wonderful thesis supervisor. I wanted to come in to ask you questions about assessment processes. Okay, and the reason is because I think it's very important that any healthcare field have some meaningful understanding of the approach to assess stuff, as opposed to just saying they were in class for this many hours and they passed this many tests. Right, so the first question, and I usually don't do this, but I thought it was important to send you questions ahead of time just because we're probably picking into data. So the first question that I want to cover, I don't know about you, but I want to cover, is whether or not there's an assessment method or program that's a little bit more likely to predict or identify expertise.
Expertise, okay. So that makes it a little more complicated.
Okay.
But first, thank you for inviting me back. It's always great to talk to you about these concepts and see how you're going to be using it in the development of your own training program. So assessment for the purpose of identifying clinical expertise. The simple summary of what research on assessment has shown us is standardized assessments are really great.
Okay.
So even what people think as the simple MCQ exam, that might be like a 5-hour sitting for a particular profession, are really good at predicting future performance.
Okay.
I'm staying away from the word expertise for now,
Sure.
But there have been large-scale studies, usually in the US, where access to data is a little easier. And you know, unanonymized data in the sense that they can track it back to a particular program in a particular school or city, and and so that makes it easy to track a record through time from like undergrad to postgrad to then clinical, and then pull through instances of complaints, which, you know, the absence of instances of complaints indicates a good clinician or a safe clinician.
Or one that has little complaint.
Or that has a complaint. But as long as their license is active and patients are not angry with them, then you assume that they're performing well. And so it's more the evidence of mistakes or mishandling or inappropriate professional decisions or not following guidelines and things like that that are audited. And so the scores on these standardized exams are always significantly positively correlated with sort of that better performance or inversely correlated with the number of complaints, right? So the better school that you go to in some of these studies, the better program, the higher funded programs, and then the higher scores and passing a national board exam, because for example, some clinicians don't necessarily take that route to licensure in the medical profession in the US. There's different paths to practice, but for clinicians that were in practice and had these assessments done and had consistently high or good performance, they had very few complaints and complications with their patients at the end. Does that equal expertise? I think the concept of expertise is been misused when it comes to clinical competence. And may not even be the right term when you think of how expertise is defined in sports or in the military decision-making type areas or with firefighters. These are other fields that talk about expertise and skill. The domains, the context in which people practice are still very different than medicine. There's so many unknowns in medicine. You don't know who's going to be on your team. You don't know the time of day. You don't know how much sleep you've had. You don't know, what patient's going to walk in depending on the profession, and so there's different kinds of expertise at play too. It's not just expertise at diagnosis. You've got to be an expert communicator and all of those things. So to that extent, no, there isn't any one form of assessment. If anything, you need sort of that portfolio idea, scanning across multiple aspects of the person's training and career, looking for indicators that they're typically higher than their cohort, let's say, or looking for indicators that they struggle. With data that I know of that look at that longitudinal perspective, what you see are the cohort tend to move together. Right? At the same, if they're in the same training program, they move together at the same pace, because that's how it's designed. And the ones that fall off it's typically related to a life event of
Yes.
some kind that
Yes.
has affected their ability to focus,
Uh-huh.
engage, just even show up, and study. So, yeah, I think it's just constant observation really would help keep track of that.
So
But I'll stay away from expertise.
that's okay. No, that's fine.
As the outcome being predicted.
Well, and this is the thing. The way that a question is formulated puts boundaries on what can be answered, and depending on what evidence is available, maybe it can't answer that question properly, but it can
Right.
point to similar proxies. But with respect to multiple choice questions, because it's stable, or even standardized exams of other formats,
Yeah.
because it's stable and everybody gets through it, it's almost like a background noise. So you'd see a differentiation possibly over time with enough data where it's like this one did this well, this one did this well. Therefore, on this thing that they all had to do, that becomes a differentiator that you can pick at across time, as you were noting.
Yeah.
So when you can track an individual with the available data better, that's what we see. The people who did better on whatever tests that were standardized that they did, they seem to have less negative things showing up in practice.
Exactly.
Okay. So sorry.
Small caveat,
Yes.
Coming at this from a psychometrician's perspective.
Yep.
The power of those studies is lots and lots and lots and lots
Of data.
of data.
Yes.
So on average, these kinds of exams or assessments have a positive predictive
Yes.
value
Yep.
in that sense. Using those, using that to identify or predict the path of any one individual is going to be
No.
fraught
Yeah.
with all kinds of complexity
Yeah.
and errors, and you won't really be able to
Yeah.
predict what's going to happen day to day or year
Yeah.
to year or even every 5 years.
Yeah.
It's only the retrospective, looking
Sure.
back and averaging across
Mhm.
multiple data points.
Is it reasonable to say that any large data set that is able to generate the construct of a group, whatever that group may be, that each individual contributes their characteristics to the group, but the group in no way predicts the individual?
Correct.
Yeah. Okay. So just as a general phenomenon.
Yes.
So instead of
But people do forget that. Like,
Yeah,
that's
why?
a
Are
really
they-
good description of it. Like,
Are-
we all bring our noise.
Yeah.
The group evens it out.
Yes.
And so you get a nice story at the end of it.
But ontologically, it's also that you're creating a bounded category, and you're not necessarily creating a bunch of categories. If you had a bunch of categories within any group, so you have a group of people who are from a particular block,
Yeah.
right? There would be things that you could average out over time about the outcomes of that block, but those individuals would be so variable between one another that if you really wanted to see an actual pattern, you'd have to have way more categories to measure way more outcomes within that group. And then you'd really see what the actual stable things were.
Yes, but you'd be diluting your data and you see this in large studies
Yeah.
looking at differentials, for example,
Yeah, yeah.
between men and women or
Mhm.
genders or
Yeah.
by other kinds of identities. You take your thousands and thousands of data points and you start grouping them into smaller categories.
Yeah.
And you lose some of that power because now
It's a
my
smaller-
noise is being averaged out in a smaller
Yes.
cohort,
Yeah, yeah.
right? That arguably are people like me, but they're not really. That
Yeah,
it's
yeah.
like on a superficial level
Yeah.
that I'm being categorized. So
Yeah.
I don't love those
That's fair.
studies for that reason because
Yeah.
those variables are just treated as if
Yeah.
they're truth.
Yeah.
And then the numbers fall where the
Yeah.
numbers fall. But
So maybe
Yeah.
it's fair to say that group data maybe is simply predictive of the group, especially when you have large numbers, whereas when
Yeah.
you start to fractionate, the power of that, just because of how it actually functions in any form of analysis, you lose some stuff.
absolutely.
Okay.
Yes.
And you pointed to, this is something that we'll get into a little bit more, but you pointed to consistent observation across time. So is that fair to use the terminology more formative assessment, less summative?
Yes.
Okay.
Yes. I mean, so I guess it depends on what philosophy you're taking in
Yeah.
terms of when someone enters training for a clinical profession of any kind, are you treating them like a commodity that's to be valued
Okay.
and invested in and grown?
Uh-huh.
Or are you treating them like someone who deserves skepticism
Okay.
and is guilty until proven innocent at
Okay.
the time that they graduate,
Yep.
right? So taking that tone means they always have to jump over a bar. And so constant assessment would just be putting them through the ringer to prove their worth and value to you.
With the approach of they have to jump over the bar.
Which is the summative only approach.
And so it's constant, that would be constant summative.
Yes.
As opposed to constant formative.
Yes, and so constant formative takes that other, obviously there's in-betweens, but, in the health professions, if you think of it as a calling, you're serving people, it takes certain kind of people that are, by and large, not selfish, let's say, willing to care for others. Depends on their motivation for signing up. But, and so if you take that at face value, investing in them means you would be assessing formatively.
Yes.
But really that's coaching, it's feedback, it's mentorship, it's constant observation with the goal of making them better for the next day and then building on that. But also something I mentioned in another conversation we were having, this idea of helping people build on their own talents. Because people can pass a standardized assessment and generally show that they're competent and they know enough knowledge, skills, whatever.
Sure.
But they still all have individual strengths and individual weaknesses that will need to be worked on. And there is no standardized assessment. There is no large group format of anything that you can put people through where they come out the other end with a list, almost like a DNA test, kind of breakdown of this is what you're made of and this is what you need to work on. The only way to get to that authentically and ethically would be coaching, like individual mentorship and multiple mentors, I think, right? And advisors to the way.
Well, if you have only one perspective, then at best you have the limits of that perspective. So whoever's giving you the feedback, whatever their preference is. Now, if they're mildly savvy and they know they have preferences, then they can say, hey, I'm telling you right now this is my preference. However, I really like the term deep features in FAR transfer. Like I like that because it's non-tangible but it's omnipresent. So the deep feature or the scaffold or the framework here is this. I need you to experiment through this so that you don't get stuck with what I am, because I am my own problem. Right? Okay.
That's rare. As an educator to have that, from what I've seen and from what I've read, very rare for an expert clinician, right, to kind of retain that sense of introspection and humility. Really, it's the humility to continue to work with people that are much junior than themselves, who in some way never age, right? Because they're always coming in that same, but then that clinician is advancing and things are changing for them.
I think the really interesting thing that happened for me through the process of obtaining my master's was the kind of accidental stumbling across the difference between more of a novice and an expert approach. So the say cardinal errors, the cardinal error of the novice being more one of interpretation, so they feel like they don't know enough, right? They sense everything, but they don't think they know what to do with it. So it's really an interpretation error more likely than not, whereas the expert learns what not to pay attention to, such that the error is just something they didn't do. Right? And they prune that over time through experience that says, every time I've done this, it has borne no fruit, so I just stop it. Right? So one of the things that I set up is to attempt to leverage both of those in osteopathic manual therapy, have a very, very stable, standardized assessment. And in doing that, you have to have thrown a bunch of tests out, because if you do every test you could possibly think of, it takes too much time and there's too much to remember. So managing cognitive load says, well, learn all the tests, right? Learn which ones bear fruit for you as an individual. Throw out the ones that don't, just don't bother with them, such that when in your normal standardized approach, at the point that you find nothing, you're like, okay, well, I can just use one of the ones I threw out. Right? So the expert, the expert throws some out on purpose, whereas the novice knows them all. Right? So then you just leverage that process and say, I want you to come from both ends as often as you can. Right? And remember, please, centrally remember that both of these things that I'm trying to get you to do are a problem. Just know the problem. Right? That's what I am attempting to inculcate in others.
And I will be really curious to see what happens with your learners.
Yeah.
Because that's the ideal, is you
Mhm.
gain expertise and you know how to think quickly
Yep.
and make decisions, and you're right most of the time.
Yep.
But you retain, like I said, that humility, you retain memory of what didn't work.
Yes.
You build a repertoire
Yep.
of all the things you still don't know,
Mhm.
and so you kind of remain open to
Yep. Yeah.
that, and then act like a novice
Yeah.
while also being
An
a
expert.
confident
Yeah.
expert, which is the rhetoric in medicine certainly,
Mhm.
and difficult to balance. So
Yeah.
I don't think that's trainable.
That's fair. That's okay.
But, people don't talk about it explicitly enough either,
Sure.
so.
I think the actual performance requirements of osteopathic manual therapy are narrow enough that it can be done.
Okay.
I think medical practice is much more, requires way more details, requires way more, connected semantic networks,
Sure.
right? Whereas I think the performance requirements of osteopathic manual therapy are narrow enough that you can really effectively manage cognitive load.
Okay.
Like that's the approach that I'm taking. See what happens over time.
Yes.
And if I'm screwing up, it'll take a while to figure it out, and then I'll have to correct.
Yes.
Okay. Now, to shift into a broad concept, do you see some value, just because of rhetoric that I'm aware of in a lot of different areas with education, do you see consistently instructors teaching to the test? And also, if that's the case, do you think changing the test and teaching to, say, the desired outcome performance would then possibly, just through sheer force of that's the test, maybe change some educators' approaches? So, there's a few different parts, I'm sorry.
Yeah, no, this is complicated. And so bearing in mind just what you alluded to, osteopathic profession versus medicine.
Yes.
So across different professions, defining or visualizing that end goal
Yeah.
is going to be very different,
Okay.
with more challenges. So
Yes.
let's just go with medicine, for example,
Sure.
right? All trainees go through a fairly standard, in Canada, medical undergrad curriculum.
Yes.
There's still large variation, but I'll say it's fairly standard. Like they all have to learn anatomy,
Yeah,
and toxicology, and physio. So there's
a good core.
components. Yeah.
Yeah.
How they do that can vary, but
Mhm.
they go through that, and then they enter into postgrad, which is where they all stratify
Mhm.
into, or diversify into their
Yes.
specialties.
Yes.
So how do you prepare this fairly homogeneous group
Mhm.
for this more diverse
Uh-huh.
training
Yeah.
program, and ensure that the psychiatry profession trainees have the foundation that
Mhm.
they need? So in terms of teaching to the test,
Sure.
that is actually where I think they fall down.
Okay.
If they're teaching to a generic test,
Uh-huh.
that's not the best way to prepare those trainees for where they
Yes.
are going to
Okay.
be applying, or
Totally
where
fair.
they're going to go.
Mhm.
It doesn't acknowledge the need for them to start pruning, perhaps, or
Okay, yeah.
focusing,
Yes.
or maybe even balancing. They keep the generalist approach, but they spend more time on that specialty, and so the assessment should take into account the fact that they are headed over here,
Yeah.
and they still need to know enough to collaborate with all the others,
Mm-hmm.
but the priority is for them to be the safest with patients who are coming for that
Sure.
expertise.
Sure.
At least that's the way medicine operates right now.
Okay.
Right? If we were to
I-
move to a more general kind of medical approach,
Uh-huh.
then everyone should know everything.
Yeah.
The challenges,
It's
but
too big.
yeah,
So-
but let's not get there.
That's okay,
Because
okay.
that's a different
Yeah. So
debate.
what that response did was just do something nice for my thought process,
Oh, okay,
right?
good.
Because maybe my question is more appropriate at the point that they have streamed to specialty.
Okay.
So once in specialty, you kind of know that the outcome performance that you would want in that specialty.
Yes.
So would that be a more appropriate point at which we have a consistent application of formative to the best of your ability? Because depending on what you're actually testing, if it's actually on a patient, I mean, we got to be really cautious and careful. But more consistent testing of the outcome performance is
Yes.
that you would want at the level of specialty.
Yes.
That would possibly change behavior.
If they were to do that well, yes.
Okay.
looking to medicine, they currently don't. Within nursing, I don't know how well they do that either, but
Okay.
if we even include that profession in terms of diversity of outcomes or end goals.
Okay.
So undergrad, fairly standard for both of those, then they start to specialize. So even nurses might choose they want to work in a hospital OR, in a hospital emergency department.
Okay.
Like, so even that, or they want to work in a family clinic.
Yeah.
All of those require different competencies.
Yes.
So when I think of what is the assessment doing and what are you teaching towards, ideally the assessment is evaluating if that person is ready for the next step.
Yeah.
And so if the next step is clinical practice, then it should be that.
Yes.
But targeted to the clinical practice they're actually wanting to go to.
Yeah,
So if they plan to go to a rural hospital, there's different sets of competencies they're going to need than downtown.
Yes, a little bit more ingenuity.
Yes, exactly. So yeah, they should take a different exam
Okay.
at that point.
Okay.
But so far, regulators don't have not demonstrated their ability to be flexible in the kind of assessment. Everyone takes the same assessment at undergrad to move on to postgrad, and then they take the same assessment to go on to independent practice.
Okay.
And they're all fairly generic.
Okay.
And don't acknowledge the need for like the pediatric specialist to really show that they're safe in that and are ready for the next step. And yeah, I don't know how you would do that, but that would be, going back to your original question, what kind of an assessment collection of assessments could help predict that expert? It's ones that are staged in ways that keep in mind where they're going next.
Okay.
Not just designed to test what they've just learned.
Yeah.
Which is also necessary, but hopefully they're doing that through that more formative, constant observation kind of mentoring process, and then assessing them as to whether they're ready to go next.
Yes. Okay.
In a targeted,
So it's almost
not
like,
individualized, but semi-customized manner.
it's almost like the pediatric specialty is going to, on some level, because of the general regulatory environment, show some competency with geriatric populations.
Sure.
It's like two complete ends of the spectrum.
Yes.
It's like, why are you testing me on this?
They are very different. Like your history taking, right? You're going to be asking a parent if you're dealing with a toddler patient, for example, but there might also be some interview strategies for working with children or nonverbal children. And so currently, yes, educators teach to the test because they know that's a stable entity. They know what.
Well, they have to.
They have to. But that doesn't help the learner prepare for what's next.
Okay.
It's sort of like they get through that gauntlet, they pass, and then they have to reset and kind of figure out like, okay, where am I?
Okay.
And how do I become this thing now?
Okay. You're good till 12.
Yes.
Okay, perfect.
Yes.
Okay. So, I'm just looking at the questions that I have here and see how to.
I may have jumped around.
No, that's okay. I did too. It's also my fault. Okay. Now, just based on the questions that I had there, I think we covered the core already.
Okay.
What I have a very, probably a very interesting preference for global rating scales.
Okay.
As opposed to checklists.
Well, that's also evidence-based.
Yes,
so,
as assessment processes. And now I think a lot of my interest in the line of questioning we've undertaken so far is trying to get towards, for myself, as somebody who's assessing people, whether or not consistent application of the same global rating scale across time, so many samples of the same outcome-based performance based on the same scale, is going to possibly make it more understandable that somebody is showing an arc towards competence and then maintenance of competence, as long as it's the same set of tests, right? So, for example, the way that I have set up my global rating scale to check assessment practices, so like them assessing a patient, where I'm talking about things like, is the patient showing any signs of hesitancy? So are they guarding themselves? Are they making faces? Is the practitioner too far away to keep them well controlled? As far as the reassessment, so there's essentially four scales, anchored 1, 3, and 5.
Okay.
And it's the assessment, so it's like how are they doing the assessment, how are they technically applying to the patient, there's another one, and then the reassessment. The only way for somebody to get anything less than 5 on the reassessment is if they did a different assessment method than the first time, right? So at least there it's, superficially it's like a gimme. Okay. But the rationale for that is I'm looking at the behavior of the learner in relation to the patient in both meaningfully assessing. So did they go far enough? So if somebody wants to assess the range of motion in the shoulder, did they take it to here or did they take it to here?
Yeah.
Right?
Okay.
So did they do what they need to do to figure it out?
Yes.
And there's behavioral anchors within that. Now, if I'm doing that over and over and over to the same person, right, then what that's going to show me is, are they committing the same error? This is what I predict. It's going to show me if they're committing the same error, and once they're given feedback, if they commit the same error again, then we have to dig deeper. Yeah. Right? What I tell people is, I'm like, listen, if you commit error A, I have no problem. But if you commit error A on test 2, I have a problem. Yeah. Right? We've got to work on this. Because the evidence that I was able to come to completely by accident in my thesis was that when somebody's told about an error, it's proved really quick. Yeah. Right? So I'm like, okay. So it's kind of bringing it all in. But all that said, to come back to it, multiple formative reruns of the same global rating scale and the same outcome performance. Is that a reasonable way to identify an arc towards competence and stabilization of competence?
Yeah.
Okay.
I mean, the simple answer would be yes.
Sweet.
I think the complicated answer is with training, right? So your assessors do need some training and constant renewal of that refresher of that training, so they understand the scale, they understand what it is that their criteria are for like a 3 versus a 4, let's say. When you use the example of the range of motion for the shoulder, I went to well, should they? Would it have been appropriate to try to extend that shoulder even further, right? Yes. And so if they didn't, was that with cause? Yes. Right? And so was the judgment appropriate? But then, those might be different questions. Yeah. Right? So the use of their judgment or the range of motion strategy was appropriate for that situation. However you do that, but then train your raters to understand what that means and then have them discuss with each other routinely the challenges of applying that, right? Because they will come up against those in-betweens, right? And they'll say, I saw this student and I really liked them, I wanted to pass them, but the way this question is, I had to give them a 2 out of 5. Okay. And, then, so if they have the opportunity to explain themselves, and then you can use those notes in some debriefing to continue to improve that rating scale.
As it stands, due to keeping overhead low, it's all me. Yes. So I completely understand the value of...
So train yourself, Sam.
I'm doing a really good job. But the value of... would the appropriate term be sensitization training to a global rating scale? Yeah. Right. I definitely understand the value. I also definitely understand the value of, across time, developing a pool of raters. Yeah. So that it's not just one perspective. I completely understand that. The problem that you run into, and I think this would be true of any form of educational institution, is with what's the term? Utility. Utility is a sort of validity, reliability, and utility of assessment. It's is there utility in having multiple people? Because can you trust their judgment? Right? You do sensitization, and then also it's well, how much do you have to pay them?
Yes, there is that. I mean, the science on that is there's some stats that you could do. Some people argue you can't possibly train a rater, but I think you can. Yeah. But you can also recruit people that are natural raters, right? That have an understanding of pick it up, have an understanding of the goal being safety, not to just ding them on every slight thing that they perceive. But therein is the advantage of the global rating scale. So the science for that versus checklists. Checklists force the rater to look at minutia, the small aspects of the procedure, let's say, which might be meaningless given the whole 5 minutes assessment, let's say. So typically checklists end up being beneficial when you're assessing a true novice.
Yep.
Like if you taught them the 10 steps towards this,
Yes.
did they learn the 10 steps?
Yes,
right?
yes,
and
yes.
now they put it together, so it's a symphony kind of.
Yeah.
And so checklist right on like say that day one of training situation, but now that you get them to make their own decisions, you
Yes.
use to a scale because people vary.
Yes.
Right? We are not consistent as much
No.
as we like to think that
Absolutely.
we are always of this kind, or we always hold this value, or
Yep.
given a situation, we will always act that way. We won't.
Yep.
And the same is true for skill development.
Yep.
Even an expert will have a bad day,
Yes.
right? I mean, look at athletes,
Yes,
right?
absolutely,
People have
absolutely.
a certain average or performance level, and
Yep.
they will fall flat.
Yeah, but that's why it's an average, because sometimes they go above.
Yeah, exactly. So there's that. There's accounting for that as well.
Yeah.
And so a scale allows you to like track all that.
Yes.
The multiple observations gives you the opportunity to
Yeah.
average it and see if it's by and large above
For sure.
more often
Yeah.
than below. Yeah.
I think across time, one of the ways that I'm going to deal with developing raters is utilize the people I have rated.
Yeah.
So the people who are familiar with having the test applied to them.
Yes.
Those who are willing and would be willing to come and provide some help and some consistency over time, because they'll be sensitized to the test because they know what it was.
Yeah.
They know what they'll be looking for because they know what they did right, what they did wrong. They'll understand through the feedback process of this stable assessment what somebody's really looking for.
Yeah.
Right? It may be argued a position on my profession that it is far more simple than many people like to admit.
Okay.
I think they often say a lot of large words that are really not required. Like really, really, really not. And also some of the things that I've read, there are people who maybe say preferentially quantitative in the research, and then you read it, you're like, why did you do that? So I have the belief, based on what I'm able to identify within my profession, that absolute fundamental stuff hasn't been explored. Like it just hasn't.
Yeah.
Right? So say if my simple hypothesis is that larger movements, when restricted, will have more diffuse effects on a body.
Okay.
One of the things that I've run as a very simple experiment is I'll test the neck,
Yeah.
right? I'll test the shoulder girdle, I'll test the vertebral column, I'll test the hip, and I'll test the sacrum.
Right.
If I treat the sacrum, almost nothing else changes.
Okay.
In isolation, instead of, most often people will use a limb to do it,
Yeah.
but you can't do that because it's like, no, I need to treat here.
Yeah.
Whereas if I just treat the hip, simply the hip, then, and I don't move the bones, I
Yeah.
just touch the soft tissue. Often the sacrum will change, the hip will change, the
Oh.
vertebral column will change,
Okay.
and sometimes the neck will change.
Right.
Right? So it's like a large movement is going, when restricted, will have a more diffuse effect. So that I don't believe has been appropriately explored. Right? So other things like that, there are claims such that
Yeah.
working on the neck, because of the reality of the vagus nerve being there, that if you treat the neck appropriately, that you'll have heart changes in autonomic proxies, such as heart rate and blood pressure.
Okay.
Right? So I actually have a student exploring that, right, with relatively simple equipment, and I said, listen, you have to know your equipment, because
Yeah.
this is going to be really simple. So, like, they're using a blood pressure cuff, an automated blood pressure cuff, so I'm like, you need to know the ranges in which this thing has funny readings,
Right.
but if you're using it the same way consistently, we should have some acceptable consistency, but you're going to have to note that as a limitation.
Yeah.
But all of that to basically say, my profession is probably much more straightforward than people say,
Yeah.
and they just make these really weird choices in research, but I think a lot of it's because they just need to get published.
Possibly.
I'm like,
Yes.
I don't know what is this? What's this question? I don't get it.
Right.
Now, freely admitting that I have my preferences and things that I'm interested in, so the things that other people are interested in should exist because it gives me the opportunity to learn from whatever they've done,
Sure.
and possibly in the form of being judgmental.
Right. Avoid some things, I guess, too.
Yeah,
Yeah.
it's like, I think that's too complicated. I don't think it's the simple concept of the principle of parsimony telling us about how many assumptions did you have to make.
Yeah.
The less assumptions, or the explanation with the least amount of assumptions that explains the most is the one that's probably the best, until we find another explanation that assumes less and explains more.
Yes.
Right? So yes, that's kind of where I feel like I'm at with my profession. Even with, I don't want to speak on behalf of anybody else, but with my understanding of assessment in healthcare generally,
Yeah.
I think that's also where we are. Broadly, I think there are assumptions being made in the testing procedures based on jurisdictions.
Okay. Yeah.
That there's probably assumptions that are incorrect assumptions that don't explain much. Right, that's sort of where I feel. I don't want to speak for anybody else because I don't have the level of expertise that you have.
Okay.
But when I look at some of the things that I can see with varying healthcare professions, like, why are you testing them that way?
Yes. There are, I mean, that's just it. It's the assumptions that drive people down one path or the other. Right?
Okay.
So, one thing I started to consider with some of the work that I've done with regulators is, one insight that I've gained early on with working with regulators was that the regulator came in with an assumption that this clinician, that the public needs to be protected from this clinician unless they can demonstrate to the regulator that that's not true.
Sure.
But the default is
guilty. Yeah.
And so the default for the exam is I need it to be really, really rigorous because I can't let anyone through that's unsafe. But there already is the false assumption that you can possibly screen everybody out that can be unsafe, right? Because there's so many different ways to be unsafe.
Oh yeah.
You can't, as a regulator in a nursing profession, design an assessment that also tests for psychopathy, let's say. Right? Yeah. So you could be letting people in that are going to be harmful in ways that are not clinically relevant.
Yes, sure.
Right. Or they may have other ethical issues and you're just not sensitive enough to pick that up because you can't put them through a 24-hour assessment or you don't have the time and resources to test them across weeks and months and observe them, right? You have to assign someone in a live observation setting, let them interact with patients and try to get closer to the truth.
Yes.
But usually it's
where
just
formative is good.
Yeah, but we don't have the means to assess applicants in that way.
No.
Because they're guilty until they can
Fair
demonstrate that they are safe. What I like about what you were suggesting, though, is that you're going to use your learners as raters.
Yes.
Which also is evidence-based, because peer-to-peer assessment and coaching can be just as effective.
Yeah.
Especially, the near-peer, like, if we're both novices, I can see your mistakes relative to what I know, and I can coach you relative to the language that we have, and then kind of grow together. But then also you're using your learners to create evidence, right, and help you advance the profession and build the curriculum.
Yeah, low overhead.
Yes, but it's not just you getting free labor, like that is actually advancing the way that a curriculum should be designed and that assessments can be managed.
The other thing that I've set up is that I will always have, so it's 3 levels. I'm always going to have them in at the exact same time.
Right.
I'm always teaching to the level 1.
Yeah.
The level 2 and the level 3 are going through the same thing again, so it's recursive repetition, right? So repeated bout effects. But what ends up happening is the level 3 ideally can give feedback to the 2 and the 1, and the 2 to the 1. But the other deal is that because people will all have a healthcare background to start, that the level 1 might come up with something that none of us would think about, right? So it's just that opportunity to leverage small groups, leverage different angles, right? And then use that near-peer feedback approach so that everybody benefits, right? So I think, all in all, I've done a decent job of integrating everything that I learned in the HSE program. Right? I think I have, but it's only because I don't know what I'm screwing up because I can't.
Right. I guess, and I mean the future will tell. Suppose as they graduate and you can get feedback from them. And,
absolutely.
Hopefully they stay and update you with their careers.
Yeah. So far, from what I can tell, based on what I have experienced within my profession and learners from a previous circumstance, they are advancing quite well. They are doing, as on a technical side, they're doing fine, if not great. Yeah. And their ability to know what they are doing and believe that they know what they're doing has improved greatly, because from many circumstances that I'm aware of, they just didn't know where they were. Yeah. So they were functioning okay, but they didn't know that because nobody was giving them meaningful feedback in the circumstances that they were coming from. So it's, as far as I can tell, everything's going fine, but it's because I thought it all through and set it up so that it works the way I think it should work. Right. Yeah, so hopefully that does it.
I mean, in some ways those principles are core to the medical profession, let's say.
Yes.
and nursing and
Yep.
a physician
Healthcare,
assistant, generally in healthcare, sort of that as you advance as a learner, you really should be helping
Yes.
the junior people behind you.
Yeah.
But it's usually the context, the complexity, and
Yeah.
within which that's applied and how it's translated, and the capacity for the more senior clinicians to support that
Yes.
in
Yeah,
the
yeah.
learners as well. So
Well, it's
since it's
essentially
just you, that's all.
yeah. Well, it's a hierarchy of feedback because people who have experience with the fundamental concept that are there longer, they can trickle it down such that when they can't function appropriately, then the person who has the greater insight comes in more meaningfully,
Yes.
as opposed to just anytime. It's like, no, oh, you need me now,
Yeah.
right? They have it.
That hasn't been figured out yet. The
Yeah.
negotiating between, I think you can do this better.
Yeah, yeah. I think that would be hard with the complexity of medical practice.
Yeah.
I think that's hard. So I want to respect your time. So thank you very much again. It's been wonderful talking to you, and I'm going to try again to get you back on because you're smart and you have good
Well,
insight.
thank you.
Yeah.
It's always fun.
Perfect.
Well, thanks for staying connected, and good luck with this.
Absolutely.
Your ideas sound great.
Thank you.